It gives me great pleasure to introduce Professor Brigitte Farou, who's a professor in pulmonology, and she's head of the Pediatric and Non-Invasive Ventilation and Sleep Unit at the Necker University Hospital in Paris, France.
I think that we learned so much from the neuromuscular patients at the start and how we could benefit other patients. So I would be really keen to know what your opinion is with regards to when we should start CPAP or when we should start NIV, because that has changed over the years.
So as an introduction, there are no validated criteria to start CPAP or NIV in children, because we don't have appropriate end-organ morbidity criteria to know exactly on which criteria and which threshold we should start CPAP and NIV. However, this is a major question when dealing with children at risk of severe obstructive sleep apnea or alveolar hyperventilation. So within this context, we performed a study where we analyzed our practice over 1 year concerning the initiation criteria of CPAP and NIV in children. And when doing that analysis, we observed that CPAP and NIV were started in our unit in 3 different situation or clinical scenario. One situation where children who were admitted to the intensive care unit for acute respiratory failure, needing either invasive ventilation or non-invasive ventilation. And because of the underlying disorders, those children could not be weaned from NIV. In this group, we had a lot of children with Pierre-Robin syndrome and children also with neuromuscular disease who were not systematically screened for nocturnal hypoventilation. Then we had a second group of patients who were less acute, who were hospitalized for a more moderate respiratory episode, and simply by performing the nocturnal gas exchange, nocturnal oximetry or transcranial CO2, we observed that the pulse oximetry and or the transcutaneous CO2 was so abnormal that it was necessary solely on this investigation to start CPAP and NIV, and it was not necessary to wait or to have the complementary confirmation of severe desaturation or alveolar hyperventilation to start NIV. And then we had a third group who were all those patients who had genetic rare disorders with an associated risk of obstructive sleep apnea or nocturnal hyperventilation, Prader-Willi syndrome, Treacher-Collins, neuromuscular disorders, and those children were scheduled for a polysomnography performed in a stable condition. And in this situation, we had abnormal gas exchange plus respiratory events on the respiratory polygraphy or polysomnography. And when we looked at the criteria, the gas exchange criteria and the sleep study criteria, we observed that having a minimum pulse oximetry below 90%, a maximal transcutaneous carbon dioxide pressure above 50 millimeters of mercury, also spending more than 2% of the recording time with the pulse oximetry below 90% or a transcutaneous CO2 above 50 millimeters was a criteria, and also a high oxygen desaturation index. And concerning the apnea-hypopnea index, all those children had an apnea-hypopnea index above 10 events per hour. So there are some recommendations available in the literature, and in particular a recommendation that comes from the US Task Force on Obstructive Sleep Apnea in Children. And in this task force, they consider that the presence of residual obstructive sleep apnea after ENT surgery associated with an apnea-hypopnea index more than 5 events per hour and an associated disorder, which can be obesity, craniofacial malformation, is an indication for starting CPAP. You can see here that when we looked at our survey, you see here the different criteria in the subacute group, so those having only overnight gas exchange recording, and those in the chronic group, thus with polysomnography. And you can see that most of the patients had 3 or 4 criteria. So it's really exceptional that CPAP or non-invasive ventilation has to be started on only 1 criteria. So there is an overlapping which comforts the decision to start CPAP and NIV. And you can see also that there is also an overlap between the maximal transcutaneous CO2, which is most often associated also with an increased time spent with transcutaneous CO2 above 50 millimeters of mercury.